everybody. Welcome to another wonderful podcast from Nation, where medicine meets real talk. I'm Dr. David Farnen, a board-certified podiatrist and foot and ankle surgeon based in Nashville, Tennessee. Today, we're very blessed to have a wonderful individual, and I'm super excited to have you. His name is Dr. Giles, and you've been a strong advocate for understanding addiction as a chronic medical condition rather than a personal failure. Please, Dr. Giles, tell us a little bit about you and your background.
Awesome. Very nice to spend time with you and with your listeners, David. Thanks for having me on. Yeah, I went into medicine because I had to. If you talk to people who do this for a job, that's I think the only reason you should do medicine is if you can't imagine doing anything else. And I was very regular center cut doctor. I was interested in surgery. I wound up in anesthesia. Fairly typical school experience and drive to help people. But then along the way, I became a patient myself. So in my last year of anesthesia training, I developed my own substance use issue. So I became dependent on, when I used to tell the story, I would say, I'd have to say the drug 2 or 3 times and people would, because they'd never heard of it before. But since then, it's become much more popular or at least widespread, which is the drug fentanyl.
Right.
So that got my attention and introduced me to an entire world of recovery and dealing with things from that side. I will say that as doctors, at least my level of training when I went through, or my time of training, I just didn't know very much. Didn't know much about the problem. I thought it was a problem of weak will or failed character or people who were lazy, and I was anything but those things. And yet I found myself with this problem. So I went through it all from the patient side of things. I went through treatment, went through recovery, stable recovery program. And along the way, I had, I guess what you would call an epiphany. And I fell in love with this branch of medicine, this sort of underdeveloped, not very popular, still looked down upon in many circles, stepchild of psychiatry maybe, or it's its own specialty, addiction medicine. But I fell for it, and I love what it can do, and it's been my mission. So for the last 20 years, I've been a full-time addiction medicine doctor, and that's taken me all over the place, from a very fancy private practice. I used to take care of you would know them, celebrities and the most well-known people in media and entertainment and television and sports and business. And then for the last 5 years, since the lockdowns and the pandemic response, I've moved all of that into telemedicine. And that's for a couple of reasons. One is out of necessity back when it was all happening. But since then, I had this lucky discovery, which is that it's actually, I think, a better way to deliver this kind of care. It's a better way to connect to the patients. And we can help a lot more people because we're not in our cars driving around. So we're growing. I'm fortunate enough to have a lot of people have joined us. We have a lot of great partners who are helping their patients. And that's a nutshell capsule of Dr. Giles, how I wound up in front of your microphone today.
That's absolutely incredible. What an incredible story. So let's get down to the physiological aspect of this. So how much do you think brain chemistry and genetic predisposition contribute to addiction? And can you explain what happens in the brain of someone with a substance use disorder?
Well, sure. You're asking the old nature versus nurture question. So how much of this is inherited? That has implications, of course, for anyone with children who's got a history of substance use disorder. We wonder if we're going to pass this down to our kids. And also if maybe the reason we're like this is because it came from our parents. The biggest study is Schuckett's twins study from the 80s, where they looked at almost 100 pairs of twins from alcoholic families by genetic history or not, and raised in alcohol. These are adopted twins, rather, and raised in alcoholic families or not. And long story short, it's about 50-50. In other words, flip a coin. So it's probably true that there are some genetic elements, but we have not been able to isolate them yet. And simpler way to say it is, of the people who have a substance use disorder, half of them have a family history and half of them don't, which means it's probably not your parents' responsibility, or it's probably not in your genes. The good news is, even if it is in your genes, the techniques and lifestyle and approaches and medications and all the things that work for substance use disorder will work for you. even if you've got a genetic predisposition or a genetic component. What happens inside the brain when this is actually really a great question, because very popular running around right now is this notion of the dopamine hypothesis. And I've seen it even creep into sales and marketing conversations where the marketing experts are talking about people wanting a hit of dopamine. The dopamine is not the feel-good chemical. Dopamine is the this is important chemical. It's like a little flag that says, pay attention to this. Most of us don't think about it, but there's a enormous amount of information that you're bombarded with just being alive. You look around the room, your listeners look around the room where they are. There's things that they weren't even thinking about that were there all along that are in your vision, in your peripheral vision, but you don't notice them or pay attention because they're not important. They're not salient. What dopamine indicates is this is important. So things engineered for our survival, or that we're engineered to survive because they're important. Things like food, shelter, companionship, reproduction. So all those things spike dopamine. When you eat, dopamine goes up. When you have sex, dopamine goes up. So those are evolutionary advantage if you pay attention to things that keep you alive, keep the species alive. But we also have a dopamine spike here. I'm going to give you a dopamine spike, David. You ready? There, a loud noise, and
Felt it.
and the brain goes, wait, what was that important? It's just a loud noise. It's just something different from what you had been perceiving a second ago. And my favorite one is if you've ever had an old refrigerator like I have, when the refrigerator clicks off, you know that sound it makes when it stops running, and you notice, and you hadn't noticed that it was running before, but all of a sudden it's off. You get a dopamine spike with that too. I don't know anybody who's chasing the experience of having his own refrigerator shut off. That's not a high we chase. So it's not the feel-good chemical. It's the this is important chemical. This matters. Now, all the drugs that we take, they pump up dopamine. So it seems like this is really important. So you have a drink of alcohol, you get a spike of dopamine, and the brain is conditioned to say, this is really important. This must be important. And the same way you learn how to walk or drive or dribble a basketball or perform surgery like you do, you practice until you get the repetitive actions so that it becomes second nature. And when you're used to managing your feelings with alcohol, your system is set up to learn how to manage that, learn that system, learn those steps, that process even better until it becomes second nature. And that's what addiction is. It's a learned habit that makes you feel good. So no matter how eventually, no matter how much it's uncomfortable and how much it costs you, it's the handle on control, the way to manage your inner life is so attractive, and so we're so evolved to pursue that you can see why it's very hard to shake a drinking habit or smoking habit or a drug habit or a Netflix habit or a scrolling on TikTok habit. All those things were built to repeat over and over again because the brain says, hey, this is important. Does that make sense?
Yeah, that makes complete sense. I never really thought about it like that, because I've always had a fascination with addiction medicine and the addictive habit. So yeah, I never really thought about it. So that's well said. So I have a two-part question for you. So some people view medication-assisted treatment as trading one addiction for another. How do you address this misconception? And then how do medicines like methadone and naltrexone work differently in the treatment of opioid addiction? And then I guess there's a three-part in terms of also, are there any new medications on the horizon that can improve addiction and treatment outcomes as well?
Excellent. Great stuff. So yeah, medication-assisted treatment. So where that comes from is back in olden times, at the end of the 19th century, there was a very popular remedy that was sold over the counter. This is before the Harrison Narcotics Act, before government regulation of narcotics. And it was a mixture of alcohol and opium called laudanum. And those two drugs in combination, you want to talk about dopamine flood, they feel really good taking them together, alcohol and opium. And it was sold in little bottles, little brown bottles. There were hundreds of manufacturers and distributors of it. And it wasn't just the housewives. It was a lot of people took this stuff. It was cheap. It was plentiful, and it made you feel great, not care about your aches and pains or whatever actual medical challenges you had. Plus, it certainly broke up the afternoon in terms of mood and feelings, and people got addicted to it. And so, in response to that, other companies sold products to try and help people deal with the addiction. And so there was one called Coca-Cola, and this is pretty widely known now, that was a mixture of the cola nut, which has caffeine in it, so a little bit of a lift, and cocaine. So in sometimes it had up to 500 milligrams of cocaine per liter, Coca-Cola back then. And if you're having trouble getting off of your laudanum, you drink some Coca-Cola, now you're on cocaine, and that is a replacement or a substitute. And although physiologically it doesn't make any sense why a stimulant should help you get off of a sedative, remember one neuron in, back to the brain, one neuron in, it's all dopamine. So the brain says, oh, this is important, drinking this Coca-Cola because I can control how I feel. So we have a long history of substituting one substance for another. Heroin came out not long after that, invented in Germany. People were using that to get off of cocaine. There's a famous story of a Dr. Halsted who was a surgeon in New York who had used cocaine from a paper he read by Sigmund Freud, and he used it to inject himself to outline the nerves in the body where you could perform surgery. So you could do what we now call a local or regional block. So Dr. Halsted mapped all those cutaneous nerves. Injecting himself with cocaine, he developed a cocaine problem. And then later when he went to Johns Hopkins, he developed an opiate problem in order to manage the cocaine problem. So that's why your question is pertinent. Addiction, or substituting drugs is something we certainly have to worry about. In more recent times, when Valium came out, and before that, phenobarbital, they were marketed as treatments for anxiety, especially the anxiety of stopping drinking. And so countless patients were put on Valium to deal with their drinking problem, and then they developed a Valium problem. In the book Alcoholics Anonymous, which is their textbook or their big book, the founder, Bill Wilson, tells a story of getting a prescription from his doctor. This is in the 1920s, like maybe 1930, getting a prescription from his doctor for phenobarbital to deal with his alcohol withdrawal. And then he drank and took the pill at the same time. It says next day had me both taking sedative and drinking. So it's a worry when you're talking about substituting one substance for another. But we know this, if you have the big drugs that are the most helpful for MAT or medication-assisted treatment are for opiates, for the opiate class. And we have a couple of big ones. So we have methadone, which came out in the 70s, which is a regular opiate. It's a synthetic opiate, but it works just like morphine or heroin. But it lasts a long time, and so you can dose it once a day. That's its main feature. And then more recently, we have buprenorphine, which is sometimes called Suboxone because it's in that. And then even more recently, one called naltrexone. We'll talk about that last. So the methadone works by putting keeping enough opiate in your system, in the patient's system, that they don't have this urge to go out and get. Back then it was heroin. Nowadays it's going to be fentanyl. And so they're less likely to overdose, so the theory goes, or have something bad happen to them from injecting drugs if the methadone is present. So that it treats the cravings by sitting on the opiate receptor so you don't have the withdrawal from the drop in concentration. Suboxone works similarly, but it's not as strong. It lasts a long time, and it also blocks other opiates. So if you're on Suboxone and if you take another opiate, it's very unlikely that it'll have an effect because the Suboxone will block the receptor. Methadone doesn't do that. And then lastly, there's a drug called naltrexone, which is a cousin of Narcan, but it's orally absorbed and it blocks the receptors without giving any opiate activity. And the idea there is if you decided to take opiates, they wouldn't have an effect. And so you break that habit cycle theoretically. Now, does any of this stuff work? Well, yes. So we know that for really high dose opiate patients, methadone is probably the better recommendation if we're going to use MAT because they're just harder to reach and it's a stronger drug, but it has problems. People on methadone are almost never only on methadone. They usually have other substances in their system. And the methadone industry is, and this is a bit controversial what I'm going to say next, but it's kind of set up to keep people in the methadone industry, if that makes sense. Keep coming back for that daily dose. It's not easy if you say, I want to taper off. They often will caution you, some partially with good reason, because you don't want to go back to the life before, but also at some point you're supposed to age out of needing usually this opiate support. Some people don't, but most people do. Suboxone is much more widely available. It's not special in specialty pharmacies or special distribution like in a methadone clinic, although methadone is probably going to be available in doctors' offices at some point, maybe in the next year or two. Suboxone is much, much more available and safer because it has this ceiling. And then naltrexone is a drug that there's an injectable form, so you can get a shot once a month or so. And that if it's a protection. You can think of it like an airbag in your car, in that it won't keep you from using, although maybe it will by decreasing cravings. But if you use, then the opiates won't kill you. So that's the way the opiate methadone, Suboxone, naltrexone world works. There's a great paper that came out in 2022 from Switzerland, and they looked at people who were put on, these are all opiate addicts, they were put on Suboxone at discharge or not. And of the ones that were put on Suboxone, nearly all of them stayed sober, about 4 out of 5, about 80% stayed sober. And of the ones who were not put on Suboxone at discharge, 100% of them relapsed. The study size was not big, but there were, I think, 40 or so in each group, enough to reach statistical significance and enough for me to be convinced that until your life is together, you should stay on Suboxone if you have an opiate use disorder. And that can be 6 months or a year or a couple of years. But I think the best analogy that I have for it is it's like a bar from your world is like a cast on a broken ankle, right? You wouldn't keep a cast on for the rest of your life because it's going to cause other problems. But you also wouldn't try and walk around with a broken ankle without some kind of support. So it's there for a time until you reach psychodynamic resilience is the term of art, but it's really until your life looks like you want it to. And then it's time to taper off. Does that make sense? That's a long answer, but methadone and Suboxone and naltrexone for MAT?
Yeah, no, it makes perfect sense. I mean, I'm learning so much. There's so much information. Obviously, you're knowledgeable and you're an expert. I've heard about the methadone clinics and Suboxone clinics and things of that nature, but you're providing insight that I've never even thought about. So,
well, and then there's the other question is, what are the future directions? Are we ever going to have a drug that's even better than this, or that treats addiction? And here's why. So I'm an optimist. The way the treatment landscape looks and the way we regard this problem, just in my practice lifetime, has changed a lot. Way better than when I started. And in fact, about half of doctors don't think that substance use disorder is a real problem. They think it's just something you just stop doing it, and that people shouldn't have this if they just decide they don't want it, which is of course not true. They just don't know. So there are a lot of branches of research trying to find the holy grail or the magic medicine that's going to fix this problem. I think they're all doomed. Now, I'd love to be wrong. There's nothing I'd rather be more wrong about than somebody comes up with a pill or a treatment or a spray or a magic amulet that makes it so we don't have these problems. But the reason I don't think and there are numbers. So the FDA last week just approved a new pain medication that is as good as Percocet in terms of acute pain relief, not chronic, but acute pain relief. And it has no opiates in it. It's not a narcotic. It's not a scheduled substance. It works on the sodium channels of specific peripheral nerves that carry pain, the slow pain fibers, and people like it. So that's a new frontier. That's pain medicine, and so maybe people don't get addicted in the first place. But the idea of treating someone who has a substance use disorder and listen, the standard would be that you can drink normally, right? It wouldn't be that you achieve abstinence. It would be that you don't ignite the habit. If you take whatever the pill is that we imagine, then you can drink like a normal person. That would be the gold standard. And I think we're not going to get there because the reason we're the most successful organism on Earth is that we interact with the world until we achieve satisfaction with it. our hands, our minds, tools, each other in groups. And the feeling of satisfaction and contentment and meaning and safety and success as an organism and as an individual those are the strongest drives we have, right? Those are the strongest drives. And if you're talking about those as bugs or deficiencies, as things that we don't want, I think you're off on the wrong track already, because we're not going to change human nature. We're not going to change, and that's not just human nature, that's animal nature, right? My dog wants another bite of cheese and she wants to sleep on the couch, and those drives for safety and security are universal among any creature that can move, and maybe among the plants too, but we don't know. But among anything that can move toward pleasure and away from pain, those drives you're not going to erase. You're not going to fix it with a vaccine, because you can't vaccinate against a thought. You're not going to fix it against with a pill, because the brain is too smart. If that worked, then the heroin would work, right? You'd take heroin and you'd feel amazing, and then you would barely take it because you could feel amazing whenever you wanted to. But what happens is the brain adjusts and it adapts to the presence of the substance, and whatever the pharmaceutical companies invent to try to make you not respond like a normal person, your brain will outsmart whatever the drug is. So I don't think that we're going to cure addiction with a molecule or with a process, or even a deep brain pacemaker, which works on Parkinson's, but it won't work on this, in my opinion.
Well said. Shift gears a little bit to something about like myself, right? Surgeons and the role of physicians in fighting the opioid crisis. So, given your experience in addiction medicine, what role should primary care physicians as well as specialists play in early intervention and treatment?
Well, that's a great question, and and it's part of my mission is to make every medical provider addiction medicine expert. I think just asking the question, and maybe even more fundamentally, just thinking about it is probably most of the battle. So there was a letter to the editor published, I think it was in 1990, and it was a review of one hospital's number of opiate dependent patients they created that were put on pain medicine post-operatively. And the number was really tiny in this. It wasn't a study, it was just a report in a letter. Since then, the authors of the letter have said this is, they feel terrible about publishing this because it was misinterpreted as a blessing for take as much pain medicine as you want. If you're there because you had surgery, you won't become addicted. And that notion is what I grew up in, if you will, in medicine when I was a baby doctor. That's what I was trained in, is if you're at the hospital for knee surgery and they give you pain medicine for your knee, you're not going to develop substance use disorder. We now know that's not true. It's also not true that anyone who gets a narcotic prescription, just to pick on narcotics for a minute, is definitely going to get a substance use problem. That's not true either. Some people feel terrible when they take it. They have an aversive response and they don't take a second pill. Those people are not going to develop an opiate problem, at least not with that medication. So the most important thing is to think about it. So as a doctor, as a surgeon, you're deliberately inflicting pain, right, as a necessary evil of the procedure to fix whatever the underlying pathology is. Broken ankle, will stick with that, or bunions, or whatever the case may be. You're going to cause pain. The nerves are going to be disrupted. There's inflammation, healing process. The opiates are very helpful, although opiate sparing strategies like local blocks and pain pumps and topicals and just splinting and casting, and also the way we talk to the patients about expecting the pain, if they're psychologically prepared for it, it actually hurts less. Not just feels like it hurts less, but fMRI studies show it hurts less when they have a sense of control. But the main thing is to consider it. So as you're writing the prescription, say to yourself, I am possibly fostering a substance use disorder in this patient. So you have to think about it. And I think if we're candid with the patients and we ask them to be candid with us, and then if you follow the work of Dr. Pasick, there are normal and abnormal behaviors. The most obvious one is I keep losing my prescriptions, or dog ate my homework. and the patient has an escalating requirement for pain medicine, bring her back into your office, right? Spend the extra time talking about it. Obviously, take a look and see if there's a pain generator, if there's an infection or something going on with the repair. But the acknowledgement that this could be a problem, it's a known, right? It's a known unavoidable. There's no risk-free pain medication prescription. And if you talk about it, then that goes a long way toward reducing the risk, right? Patients are aware of it. They're not there to suffer needlessly by keeping all the pills in the jar. By the same token, each time you take a dose, it becomes a risk benefit trade off rather than leaving it under the blanket of saying, oh, this is totally fine because you had surgery. Take all the pain pills that you want. That's my recommendation for preempting these problems.
Yeah. In certain particular areas too, you get those subset of patients, and it's difficult. Whether we do bunion surgery or ankle fracture surgery, I mean, those patients are going to have pain,
Yep.
and there's no getting around that, right? And
Yeah,
he,
no pain medicine is a bad strategy also,
right,
because they're going to come up with their own solutions.
right.
And one of their friends is going to have some pills, and maybe those pills are counterfeit and dangerous, or they're going to drink, or they're going to take too much Tylenol. There's no way you're getting having zero risk of,
Right.
right? Yeah.
So let's talk about stigma and barriers to treatment. So stigma is a huge barrier, obviously, in addiction treatment. How do you think we can shift the conversation, encourage more people to seek help?
Well, I'm trying to do that on a personal level by talking about my own experience, because it's been a very long time now. But the just most people know somebody who has a substance use disorder, but everybody knows somebody who has dealt with a substance use disorder. We just don't tend to talk about it. Although there is something I noticed, which is nobody wants to get sober, but once they do, they won't shut up about it. Right? Everybody is proud of their accomplishment. They will tell you that they used to have a drinking problem, but they don't like talking about the one they actually have. I think we've things are much better than they were 20 or 25 years ago in terms of stigma. We've had lots of television shows discussing it, right? Whether that's the Celebrity Rehab or Nurse Jackie shows where you're seeing up close what it is. Many of the TV shows feature this, but not in a glamorous way anymore. People recognize it as a problem, and we see in the national alcohol consumption statistics that young people are drinking less. There's a bunch of reasons for that. Opiate overdoses are down 2 years in a row now. There's some good reasons for that, and some more morose reasons for that. We may be running out of people to kill with opiates. That's possible. These tariffs that you're seeing in some part are to try and tighten up get our neighbors to tighten up their borders with fentanyl coming across.
Mhm.
So we're talking about that, that is national policy being animated by talking about substance use disorder and addiction. We're in tariffs. So I think we have moved a long way toward less stigma. But I think the people that we need to reach about reducing stigma are the ones actually doing the suffering. I
Mhm.
think most folks are generous of spirit, and if somebody makes an honest effort to get their lives together, most people are they'll celebrate that, not just be supportive. It's what you think about yourself. If you think about yourself as defective or broken or something more wrong with you than just you stumble down this substance use path, that's kind of a hazard to being a human being. If you think that you're special in a bad way because of that, then you generate your own stigma. That's where we should concentrate. I think not getting others to accept substance use disorder. It's much more. Now, some people are never going to accept it, I guess, like other things, but in general, it's better. It's about getting the individuals to not regard themselves as marked people, or the people are afraid that if their friends found out, they would suffer endless embarrassment. I think what's underneath it is, at least speaking for myself, I was afraid that if people found out I had this problem, that not only would I get kicked out of my profession, but that I couldn't drink anymore, right? Because people would say, "Oh no, you can't drink because you had a problem." And when you're on the near side of it, before you break through and and put the plug in the jug, as they say, that's scary. It's terrifying to contemplate life without some chemical to get you through. Once you're on the backside of it and you realize that those chemicals were poisoning you and killing you, well, then you don't miss it. I mean, you don't. It's not like it was. It does. You miss it maybe, but it doesn't drive you like it used to. So that's what I would like to see. I would like to see the people with it say, "Hey, wave the white flag." Right?
Right.
I need help. And to a large extent, Dave, that's part of what my mission is to talk about it and to get people talking about it in a conversation so that two friends are able to be honest with each other and say, hey, I think I'm not sure, but I think this may have crossed over into a problem. And then you can begin to get help.
Yeah. 100%. 100% agree with that statement. So let's talk about, one final topic here. Let's talk about the future of addiction medicine. Are there any emerging technologies or new treatments in addiction medicine that excite you?
Yes. Yes. There's some very cool things. So yes, for sure. So we don't know. Here's the big problem. The biggest problem. If we could solve this, we could make a major sea change in this whole problem. Is people who it's relatively easy to get sober, or to get some abstinence. But what's difficult is to stay abstinent. And the right word at the right time from the right person will help you stay on track. Right. The problem is they don't know when to call or when to text. And so we have behavioral tells, like from poker, where people can tell what you're thinking or what you're about to do
Mhm,
based on the way we do stuff. Back to that learning thing that we talked about.
mhm.
We observe animals in their habitats, and you can tell when they're about to whatever go into rut, or when they're going to all leap off the branch at the same time if they're birds. And we have the same thing. And if we could figure out what an individual's patterns are, then almost like a Richter scale, you could tell the foreshocks before they got into trouble. And then using technology and reminders and a network of supportive people, you could get that text message or phone call or TikTok post at just the right time
Right.
where you reconsidered, right? You reframed whatever you were anxious about, whatever your discomfort was, it was maybe going to lead you. So, distributed behavioral neuroeconomics facilitated through a technology platform is a fancy way of saying the right message at the right time.
Hmm.
So I think we can get there because of all the digital lint that's collected about us, and we don't know the answer to this question yet. No one knows yet, but I think we can reach critical mass on the data and get an answer. So I think that's on the horizon. And if you become part of that, then we'll get data on what works, right? So maybe it's a phone call, text message doesn't cut it. Or
Right.
maybe it's the right wording, or who knows? We don't know, but I think the data will answer. So that's one cool thing. The other cool thing that's got me super excited is remote monitoring. And that's a gift of all this high-speed internet and you know chips getting smaller and smaller. So we're in early trials of a remote patient monitor. Our patients detox in residential treatment centers. We have about, I don't know, 400 patients at a time that we're looking after, and they have the on-site staff take vitals and get reports on the patients, but there's a lag between when the patient's symptoms appear and when we hear about it. And
Hmm.
so remote monitoring gives us essentially telemetry on patient vitals. So we can see, because no one should go into detox and have a worse outcome than if they'd stayed at home.
Right.
We know that, but that's staff dependent and monitoring dependent and rounds dependent, and so we have trailing physiologic indicators that sometimes trail too far behind. And patients, unfortunately, smuggle in drugs to facilities, and they'll use them surreptitiously, sometimes to disastrous effects. So being able to monitor them remotely at a central nurses, like a telemetry station, using telepresence, those are, I think, two of the most awesome technologies on the horizon. I went to the ATA last year, which is the telemedicine conference,
Mhm.
and believe me, there's some serious geniuses cooking up all kinds of stuff for solving these two problems, but a bunch of other sentiment analysis, and using some of the dating app technology for proximity support. So you can get on a list of, you're feeling crispy, like you need a drink, you're out on vacation or you're at somewhere, and then you can get hooked up with somebody else who's trying to stay sober, and you can support each other rather than be out there, lone ranger. So there's a lot of cool things on the horizon.
Right. That's incredible. Like, think about, I mean, where technology has come and where it's going to take us, where exactly like that. Like, could you imagine that even just sheer 10 years ago? You know what I mean? Like, how many lives that could have saved, right? Like, I mean, technology is really, I mean, for better and for worse, of course, but
So one time, I'll tell you a quick story. One time when I was brand new in recovery, I was flying to visit my grandfather who was dying. This was the come say goodbye one last time. And so I was less than a year sober, so I was kind of anxious dealing with my new life and heading into a emotional tough environment, family and death and all that stuff. And I was at an airport and I was feeling like I sure wish I could talk to somebody. And I learned this trick from being in a meeting, in a recovery meeting, that you can page overhead. And so I did that. I went to the white courtesy phone and I paged Bill Wilson to gate 19. And, the operator just took the page and made it. And I waited. And about 5 minutes later, somebody came over to the white courtesy phone and said, "Friend of Bill?" I said, "Yeah, friend of Bill." And we had a little meeting there in the airport, and I felt better, right? And maybe he felt better also.
right.
So that's a analog, low tech, involves the PA system solution, but now we have all these smartphones and cool devices that we can more easily help each other. My friend's son Zelnick is got one called Groups Recover Together, the idea of which is putting people together. But yeah, there's no unified platform. I mean, you could imagine it could live in one of the existing very popular ones. It could live in TikTok. It could live
Right.
in X, right? And there's a community, and there might be some settings for private. I'm not sophisticated enough to know,
Same.
but maybe there's a way to do it, like a Facebook group where you could support one another in that
Right.
in that environment and use the forces of technology for good rather than alienation. I think there's a lot of avenues in there.
So with that said, I want to say thank you for joining us. Do you want to just tell our subscriber list and our listeners your contact information, if they can reach out to you, if they really liked hearing what you had to say, and if they have any additional questions, where they can reach you?
You bet. I'm Dr. Jason Giles, DrJasonGiles, on all the socials. So you can reach out to me there. X is probably where I spend most of my time on that. And I'd love to hear from you guys. What's working for you? What helped? What do you want to hear more about? I'm taking the leap of getting out from behind the desk and talking to people. So I'm open. AMA, as they say, right?
I
AMA.
love it. And we're sure blessed to have you, and the amount of information and insight you put on this podcast was absolutely
Well,
incredible.
you ask great questions. You made it very easy. These are questions from a very, very smart person.
Well, thank you so much. So, guys, that's a wrap for another amazing episode of MedNation Podcast. If you enjoyed the conversation, make sure to subscribe so you never miss out on the latest in medicine and healthcare. Leave a review, share with a friend, and let's keep the discussion going. Of course, follow us on social media, as well as follow Dr. Giles on social media and all his socials for more insights. And stay tuned for more expert interviews and deep dives into the world of medicine. Until next time, stay curious, stay informed, and keep pushing the boundaries of healthcare. Thank you, everybody.